along with our partners at Unity Health and Meritor, to the talk, Menopause, Hot Flash or Power Surge, what every woman needs to know. And men that are in this audience as well. So, before we begin, I do have some housekeeping details. First of all, for those of us in the room, the bathroom is out to the left and sort of right around the corner. And you can get out through that door or that door. For those of you that are on the webinar and in the room, this is being recorded, so it'll be available the end of the week on the UW Health website. For the benefit of the people on the webinar, your computer screen should be showing two windows. The box on the left, which says housekeeping, is the viewing window, which shows our speaker slides, and to the right is the go-to webinar control panel, which allows you to control your audio and ask questions. The control panel is set to automatically collapse to the right side of the screen, but you can open and close it by clicking on the arrow. If you want to have it open all of the time, go to the View menu and uncheck Auto Hide Control Panel. If you have any questions during the presentation and you're on the webinar, please type the question into your question box and press send. Your question will be sent to our facilitator, who will hold all questions until the end of our presentation. We've allowed plenty of time at the end to address questions from both our webinar and in-person guests. So now I'd like to introduce our guest speaker. It's Dr. Makeba Williams, and she's the UW Health OBGYN practitioner. She attended medical school at Meharry Medical College in Nashville, Tennessee, and completed her internship and residency at Virginia Commonwealth University Health System in Richmond, Virginia. She's board certified in obstetrics and gynecology, and Dr. Williams has extensive experience caring for women of all ages. Her advanced knowledge and expertise in this area earned her the Certified Menopause Practitioner designation from the North American Menopause Society. Dr. Williams sees patients at our partner clinic, Unity Point Health in Monona, not far from here. Please join me in welcoming Dr. Makeba Williams.
Well, good evening, everyone. Thanks so much for coming out to join us. And I had a look at this afternoon, which, by the way, has given a few curious men in here. Menopause is a hot topic. I think we have a little bit of feedback, so we're going to work out the technicalities. Give us a moment. We'll try it again, maybe. So, you keep talking, we'll see what we can figure out.
Here's the sound turned on.
Does anyone have a computer with sound? Can you turn it on? This is where we say everyone silence their cell phone. Ritual. You're too. Might be better. Okay. Looks like we're good. Just enough to give me a little hot flash. And if I needed any, other prompting. So in 1998, menopause.org reported that there were more than 477 million postmenopausal women. And that number is projected to rise to more than 1.1 billion by 2025. That's a lot of women sweating through what one generation dubbed the change. I'm from Alabama, and that's what my aunts and my grandmothers, and that's what they call it, the change. It's that time in a woman's life where things get a bit rearranged physically, emotionally, where we get very close to the edge, where we feel like we want to just throw up our hands and just give in to the symptoms and just go with the flow. But that is precisely what we should not do when the flow the flow. You got it. And flow. Stop. While menopause is associated with many changes, many of which are characterized very negatively, we can actually thrive in menopause. So we are going to have some audience participation tonight. Okay. So I want to know how you guys characterize menopause. Can I get a show of hands for those of you who think life as you know it stopped and you have to settle for a new normal? A few. Okay. And what about those of you who think, although the change is inevitable, you don't have to let menopause define you? Good. And for the couple of men in the room, how many of you are afraid that the love of your life, pre-menopause, will emerge as a much different woman post-menopause? You can be honest. Well, tonight I want to shatter the very old, the very tired myths of menopause and offer some information and tools, we'll call them power tools, to help redefine and reframe how you think about menopause. Popular culture would define menopause as a time when women are like these 7 dwarfs: itchy, bitchy, sweaty, sleepy, bloated, forgetful, and psycho. Can anyone relate? Yeah. As an OBGYN who works with women every day approaching the change or going through the change or dealing with the aftermath of the change, I've got to tell you, the 7 dwarfs, that's yesterday's menopause. Your grandmother's menopause, perhaps. Today's menopause is a bit more like frozen. And just maybe after listening tonight about the inevitable midlife change, you'll leave empowered and transformed like Queen Elsa. Like if you have to go through menopause, wouldn't you rather be a little icy and cool? Yeah. Women have experienced menopause for thousands of years. In fact, 2,000 years ago, women went through menopause in their early 40s, and then they died. Yeah. The difference today is that women live far longer beyond their menopause. In fact, today, women will generally live 1/2 to 1/3 of their life menopausal. So here's menopause by the numbers. The average age of menopause can vary widely from 40 to 58 years. It occurs on average at age 51, and most often occurs between ages 45 and 55. By 2020, we expect that there will be more than 50 million women in the United States over the age of 51. The median duration of very severe hot flashes is about 10 years. And again, as life expectancy in this country continues to increase, we're going to spend 1/3 to 1/2 of our lives in menopause. So that's a whole lot of life to live. So again, do you want to live that life as a dwarf or a spirited, powerful queen? I think I want to be in the latter camp. So you're actually a warm-up to my next big gig. I have a 3- and 5-year-old. And so when I leave here, I'll go home and I'll read bedtime stories to them. And those 2 children, one day soon, will see me go through the change, and will see me hopefully not being itchy-bitchy, sleepy, and psycho, but hopefully I will be able to practice what I hope to preach tonight and not let those children or the changes manage me. Like you, I seek to be empowered to live my healthiest life, especially during my menopausal years. So let's talk about what exactly menopause is. I had one patient tell me that she Googled it and landed on the menopause Wikipedia page and quickly felt like she was reading the script to that classic horror movie, The Exorcist. So here's our first step in reframing menopause. It's not like The Exorcist, but maybe it's more like the hilarious Menopause, the musical. We'll talk about some medical facts about menopause. It is simply the time when women stop having periods. We diagnose it after a woman has gone 1 full year without menstrual periods. And this is a result of the ovary losing its function and activity. Menopause may occur naturally as a result of the ovary aging, or it may occur after the surgical removal of ovaries, or after a woman has taken medications such as chemotherapy or radiation therapy. Before we arrive in menopause, though, most women will go through perimenopause. And that term, perimenopause, literally means around menopause. It is this time period between the normal menstrual cycle and when that begins to change and the final menstrual period. It is a time when ovulation becomes more infrequent, and women will report that their menstrual cycles begin to change. They either get shorter or longer. Many women will experience other symptoms such as hot flashes or night sweats, and the menopausal symptoms tend to be more intense and severe during this perimenopausal period. Some women will start experiencing perimenopause as early as age 45, and the transition up to menopause could last about 6 years. During this time, women experience many changes to their health, be it physical, psychological, mental, and sexual. Now, we've all grown up being told we're special, we're unique. Isn't that what we tell your daughters, what you think about yourself? And there's no time in a woman's life where that individuality comes front and center more than in menopause. Each woman's menopause experience is very different. Many women who undergo natural menopause report no physical changes at all. And then there are others who will experience what I call the suffering 7. Hot flashes, difficulty sleeping, memory problems, mood disturbances, vaginal dryness, decreased libido, and weight gain. Those sound fun, right? You know, lifestyle and demographic factors as well as attitudes all influence your perception of menopause. The menopause experience, including perimenopause, can be perceived simply as the end of menstruation. After all, menopause, like puberty, is just a normal developmental event. But some women may view the change as the end of their fertility or liberation from the possibility of pregnancy. Or she may grieve for the children she never had. For women who have experienced an early or unexpected menopause, their whole experience may be perceived very negatively. And the level and degree of your menopausal symptoms will obviously affect your perception of menopause. Some women will have troublesome symptoms, and then others will have no symptoms at all. And diverse social and cultural differences can impact your outlook on menopause. Imagine, if you will, if your society or your group, your tribe, your hood only values you for your ability to procreate, or if your partner thinks of you as a dried up, unattractive old prune versus someone who actually now doesn't have to worry about contraception and is more sexually appealing. Cultural messaging and issues around self-esteem affect your menopause. In Asian cultures, for example, older women are more valued for their wisdom and experience very few symptoms in menopause. again, women with negative attitudes towards menopause tend to have more severe symptoms. So perhaps it's time for an attitude adjustment. Maybe you aren't having hot flashes, you were just having a short private relationship with the prophet. Or you're still hot, for sure. You just come in flashes. So let's talk about some of the symptoms that can push us over the edge toward the menopausal cliff. As a result of the ovary declining in function, the quality and predictability of the hormones produced by the ovary changes. Estrogen levels begin a major decline about 1 year before menopause. And when the vagina is deprived of estrogen, it loses its collagen, its fat, and the ability to retain water. And as a result, those vaginal walls will shrink, and the normal pattern of ridges that are in the vagina flatten out and disappear. I often joke and tell my patients, you lose the wrinkles in your vagina, and then they just start creeping up in your face and around your neck and all those other unsightly places. Many women will experience itching and discomfort with sex. And some will have frequent urinary tract infections, will experience urinary incontinence, leakage, and the need to go to the bathroom frequently. If that happens to any of you, again, the bathrooms are down the hall. So what happens to the bones? The effect of estrogen on collagen also manifests in changes to the density of bones. Bone mass and collagen both decline in parallel after menopause. And most women begin to lose their bone mass at the age of 30. The ratio of bone destruction to bone building quickly or accelerates after menopause. And so this decrease in bone mass associated with the lower levels of estrogen increase your risk of osteoporosis and osteoporotic fractures. So again, more time for audience participation. What do you think are the top 3 concerns of patients going through menopause? Sleeplessness. Sleeplessness? Fragile bones. Okay. Hot flashes? Foggy brain. Any others? Sneezing and coughing. You guys are pretty good. You guys are pretty good. I think I heard the most common ones. We'll start off talking about vasomotor symptoms or hot flashes. And then we're going to talk a little bit more about issues down there, like vaginal dryness, loss of sexual function, and the fogginess that comes along with menopause. Vasomotor symptoms are commonly known as hot flashes and night sweats or hot flushes, and they represent menopause's most bothersome complaints. 75% of women will have them, and they're severe in 10 to 15% of women. The highest occurrence is during perimenopause and then the first 2 years of postmenopause. The average duration of severe hot flashes is 10 years, and that's based upon very recent data. Some women will have persistent, lifetime vasomotor symptoms, but fortunately for most, they do decrease in intensity and frequency over time. How many of you have experienced a hot flash? I guess the 2 men in the room tonight. We'll educate them, or perhaps I should let one of you educate them. A hot flash is a sudden onset of reddening over the skin of the head, the neck, and the chest, and it's accompanied by this intense feeling of body heat, and it's concluded by like a sweat, a very intense sweating, and it can last for a few seconds. In some women, it will last for several minutes. If you're lucky, they occur rarely, but in many, they occur every few minutes. They tend to be more frequent at nighttime and during periods and palpitations where the heart rate might increase 7 to 15 beats per minute. And in many cases, it can take the skin 30 minutes to return to its baseline. African American women and obese women tend to have more severe hot flashes and more frequent hot flashes, and smokers also tend to have worse symptoms. So here's our first set of power tools. I like power tools, I might do this. Give me something with power and a battery and a motor, and I'm like, so there. So I'm all about us finding power. One of the first things you can do is to find what triggers your hot flashes and avoid it. Smoking, caffeinated beverages or hot beverages, alcohol, stress, spicy food, all may trigger a hot flash. It is Cinco de Mayo tomorrow, so you should think about that when you're having your spicy Mexican food and your margarita. But perhaps that's how you deal with your stress. So just keep it in mind. Last week, I had a new patient visit me, and she had been on estrogen therapy over the years, and she said one day she realized that her trigger was sugar. So she did her own little experiment, and she found the more she ate sugar, the more hot flashes she had. So she cut out sugar in her life, and the frequency of her hot flashes markedly decreased. Again, menopause is experienced differently for every woman, so you have to get in tune with your own body and figure out what your trigger is. When a hot flash does occur, drinking a cool drink or running your hand under cold water tends to help shorten the episode. And then there are other common sense measures, such as packing a tiny fan like this, carried around in your purse. I've had a few hot flashes today. These come in handy. As well, you can lower the temperature in your bedroom or in your house. That might be helpful. Wearing layers is also helpful. So when you feel that hot flash, you can take a layer of clothing off. For my patients who experience a lot of night sweats, I recommend that they put ice packs underneath their pillows, so if a hot flash comes on, you can flip your pillow over and get instant coolness to the back of your neck. Reduce your stress. Things like exercise, yoga, relaxation training, mindfulness, and meditation training can all reduce stress and help you feel better psychologically. And as I said earlier, stress makes the symptoms worse. So to the extent that you can incorporate healthier lifestyle behaviors in your regimen, in your routine, you can improve your hot flash symptoms. So two things happened to me yesterday, and I thought they were just really ironic, given that I was doing this talk. So for those of you in Madison, and if you're members of Costco, you probably got your Costco coupons, and I always love flipping through them. And so I flipped through, and I don't know what page this is on, and I don't endorse any particular product, but I did notice that there is a $5 off coupon for Estroven, maximum strength plus energy, for multi-symptom menopause relief. Very interesting. So if it's in Costco, it obviously is an issue for many women. And then late last night, I got this text message from a friend. Do you recommend Estroven over the counter for mood, memory, stress, hot flashes? Falling apart here, laugh out loud. Perhaps she saw this in her Costco coupon book. And as you can see, my response to her is that over-the-counter and herbal medications have been used widely for the treatment of hot flashes and night sweats without any good data to support their use. So I told her no, I don't necessarily recommend them, and maybe she tuned into the webinar and can get some advice. So what about hormone therapy? Numerous studies show that estrogen represents the most effective treatment for menopausal symptoms, vasomotor symptoms, and related issues such as impaired sleep, irritability, and decreased quality of life. Hormones hormone therapy is the most effective treatment for hot flashes and night sweats. The use of hormone therapy should be consistent with a woman's goals, her treatment goals, the benefits, and the risk for each individual woman. And this benefit-risk ratio will change as a woman ages and undergoes different health issues. When we prescribe hormone therapy, it should be given at the lowest dose possible to achieve symptom relief. Hormones can be administered orally, through the skin, or even through the vagina. Attitudes and data about hormone therapy have certainly changed over the years. In 1960s, hormone therapy was promoted as the fountain of youth. Then in the 1970s, there were reports that the use of estrogen alone could lead to endometrial cancer, blood clots, and high blood pressure. Researchers then found that adding progesterone to the estrogen could prevent endometrial cancer. By the 1990s, it was believed that hormone therapy offered many health benefits, such as the prevention of heart disease and osteoporosis. Then there was data to suggest that in a major heart study, it actually increased the risk of stroke. So this data was conflicting, it was all over the place, and so the medical community wasn't really sure what to recommend and what to do. And to settle that question about the use of hormone therapy for the prevention of chronic disease associated with aging, the National Institutes of Health in 1993 launched the Women's Health Initiative. Researchers were expecting to find that hormones prevented the chronic conditions of aging, but they were startled to find that rather than being what we say is cardioprotective or protective of the heart, there was actually a significant increase in cardiac events as well as a higher incidence of breast cancer. So in July 2002, when the Women's Health Initiative study data were reported, there was a swirl of controversy. The media's depiction of these results led to many women abruptly stopping their hormone therapy over their own concerns regarding their health risks. However, a lot of time has passed and more data from those trials have been reanalyzed, and what we now know is hormone therapy is beneficial for younger women who initiate the therapy earlier in their menopause. So the bottom line, after 14 years of reanalysis of the Women's Health Initiative study results, and as well as more recent studies, we know that for the right patient, hormone therapy can be beneficial. I'm often asked about natural hormones, especially here in Madison, where I find that women seek a natural, a very holistic approach to health care. So the hormones used in the Women's Health Initiative were a mixture of estrogens from the urine of pregnant horses. You can't get any more natural than that, right? Perhaps. And that was Premarin, and Prempro, which was a mixture of the same estrogens along with medroxyprogesterone acetate, the progesterone that I spoke about earlier. These hormones are not exactly identical to the hormones that the ovary produces. So when the safety of these hormones was questioned, people thought, well, let's find a natural solution to what for our symptoms. And these natural hormones are often purchased at compounding pharmacies, and they're not FDA approved. And thus, their quality and safety are not well established. And many will promote these hormones as natural, but they're not. They're actually, all these hormones are synthesized starting from a molecule. Most of them come from a German manufacturer. And when the FDA has analyze these compounded hormones, they find that about 35% of them will fail standard quality tests. actually do more harm than they do good. And because these custom compounded hormones haven't been tested by the FDA for effectiveness or safety, FDA-approved hormone therapy is preferred should you require hormone therapy. Clinicians or companies that claim to measure your hormone levels and then develop an individual dosing recipe for you ignore the fact that we don't know what the standard dose should be. Should you have hormone levels equal to someone who's 25 years old? It's quite natural for your hormones to decrease over time. There are many who would suggest to you that give me your saliva, I'll test your hormone levels in it, and then we'll come up with a recipe for you. But hormone levels fluctuate. Are you having a hot flash over there? You need my I'm getting a hot flash just thinking about hot flashes. So we don't know what a standard level is. When you give hormone therapy, again, it should be given for symptom relief at the lowest dose possible. So I caution patients about using natural hormones. Individualization of hormone therapy is so important. So if you have concerns, please talk to your doctor about it. Can we talk about the vagina for a little bit? Vaginal symptoms affect 20 to 45% of period and postmenopausal women. I had a patient in my office this morning who was in tears, who almost brought me to tears because she said after 18 years of being in a relationship with her husband, her vaginal dryness was really impacting their level of intimacy and their level of their relationship. Because she says, my vagina feels like it has razor blades in it. So as a result of these sorts of symptoms and decreasing libido that naturally occurs in both men and women over time with aging, this is very, very distressing. And this is something that you should talk to your doctor about. So audience participation, say vagina. Vagina, vagina. I want you to go to your doctor and talk about your vagina. So my goal here is to give you power. You said the word vagina. So I want to tell you about this little story. So recently I walked in to one of my exam rooms and I met with this new patient. I asked her the questions, you know, like, why are you here? She told me she was here for her annual exam. So we talked about any health problems she was experiencing, any complaints or concerns. She said, no, I'm just here for my annual exam. I asked her, you know, how many babies have you had? And then I asked the question, do you experience vaginal dryness or discomfort with intercourse? And you know what she did to me? She said, shh. So I'm like, all right. I'm also an obstetrician, so people bring in their babies. They're often sleeping. She was 57. She didn't have a sleeping baby. And then I thought, well, maybe somebody else crept into the room, and I looked around, and there was no one else in the room. She was just very uncomfortable talking about this. So I moved in a little bit closer, and we continued our conversation at a whisper. So this topic really, really, really made her uncomfortable, and she told me that she wasn't expecting this very common issue of vaginal dryness, and it really was beginning to take a toll on her relationship with her husband. And she said to me, I had expected hot flashes and moodiness, but no one told me that the vaginal dryness was going to be really, really bad. She says, it's just not something that people talk about. So we moved on to the exam. I placed the speculum, and guess what I found? A very dry, a very pale vagina. And she had already begun to use lubricants like Afterglide and KY jelly, but they just were not doing the trick. So we talked about vaginal estrogen. I prescribed it, and she began using it. So I saw her for follow-up several weeks later, and she was much more relaxed and open about her vaginal symptoms. Actually, one of my nurses said to me, she is just like talking about her vagina. You know, but she didn't want to talk to her partner about it either, because she's like many women I hear. They don't want to make their partner feel bad, so you just tolerate it and go with it, and you just go with the flow. And that is not what you should do. And thankfully, not only does she now talk to us about her vagina and her vaginal vagina, she said she called her sisters who live in other states, and she has become my vaginal estrogen evangelist. So let's talk about what's going on in the vagina. In premenopausal women, the vagina is lined with many cells that keep it well lubricated. And estrogen is the driver in keeping the vaginal tissue very healthy. So the loss of this estrogen affects the skin of both the vulva, so that area outside of the vagina, and inside the vagina. There's also a decrease in the overall amount of secretions at the time of menopause, so things just don't glide easily. So you've lost your wrinkles, you've lost the elasticity, and things are just, it's like sometimes like sandpaper. And there's also an increase in the acid-base balance in the vagina. So women will report itching and irritation and burning, pain with intercourse. And because this vaginal tissue is so fragile, a lot of women will also complain of bleeding after intercourse. So our first line of treatment for the symptoms of vaginal atrophy are to use vaginal moisturizers. And as you can see, you Google vaginal moisturizers, and this is what you will find. Or just go down the aisle at Target or Walmart or wherever you shop, and you will find a plethora of those things. I just like to throw this in as a word of caution, ladies. Over the years, I've been doing this for about 13 years, and I've seen all sorts of things go into the vagina. You must be careful. It is a very special place. I caution you about putting Vaseline and Crisco. When I was in Virginia, they were putting Crisco in their vaginas. But be careful, because those sorts of things can lead to more yeast infections. Oil-based products can erode condoms. But there are many good options on the market. And if you've tried moisturizers and that's not really working, I do encourage you to try a vaginal lubricant immediately prior to intercourse to decrease the amount of friction. And if you've done those things and it's still not working, one can consider estrogen, as it does promote increased blood flow and can bring back that thickeness and plump up the vaginal tissue, brings back the water and collagen content. So, some more power tools. Number one, you need to talk to your doctor and talk to your partner. Let your partner know what's going on. Don't suffer in silence when there is help to be given. Wear cotton underwear. Thankfully, there have been so many improvements in cotton underwear in both the way that they look, but wearing cotton can decrease the amount of friction and irritation, as well as it lets good air flow through there. And also pay attention to your vulvar hygiene. Yes, I've seen Crisco. I've also seen people like bathing in Clorox and using harsh abrasive cleansers and things like that. That may be the extreme, but be very careful. The vagina doesn't really need a lot of help cleaning, so just bathe normally and you should be fine. The brain and the vagina are alike in that they are, you use them or you lose them. Regular sexual activity promotes good blood flow to the genital area. And using hormone therapy to treat some of your symptoms can help with your libido. If we can take away the pain and the discomfort and the dread of having intercourse because you feel uncomfortable, perhaps your libido and your feelings of sexual interest may increase. So someone talked about fogginess. I think someone over here mentioned fogginess. How many times have you gone into a room and forgotten why you went there? Yeah. Every hour. when you go down the list. And you just go down the list. Yeah, I always wondered why, my great-grandmother would just start calling out names, and now I know why. I have 2 children, and sometimes I get them confused. So, memory and cognition are a very frequent complaint during this time period. So what I'm about to tell you now might be quite surprising. My mother did not like to hear this when I shared it with her, but although it's reasonable to consider whether hormonal changes, particularly the loss of estrogen, might be a contributing factor to memory and cognition loss during this time, there is no evidence that memory and cognition decline because of natural menopause. This is a part of natural aging, and this is why we need to make lists and use memory strategies. What about depression? What do you think menopause affects depression? I see a few. There are several studies of midlife women suggest that depressive symptoms actually are not more common in midlife women or in menopausal women. Actually, depression is highest among women with younger children. So, depression, less common, not more common in middle-aged women. And we cannot link menopause to psychological distress. Many of the psychological or mental problems encountered during this period may be due to life experience. Many of us are stretched thin. We may be dealing with floundering relationships, challenges at work, changes in our own self-concept and esteem as we age. Perhaps you are dealing with an empty nest syndrome, or you are dealing with your daughter or your son who's going through puberty and the challenge that brings. And then maybe some of you are dealing with children who are returning home, or you're taking care of your aging parents. There are a myriad of things that can affect how we are feeling psychologically and mentally during this time period. And although hormone therapy can have a positive effect on your mood, it is not an antidepressant, and it shouldn't be used to treat depression. Here's the bottom line. What is not shown to be affected in menopause is our mental health. You can't necessarily blame menopause on everything, or we can't blame everything on menopause. Sleep patterns are indeed affected during the menopausal transition. Hot flashes are more frequent at night, and they do interrupt sleep. It is this lack of sleep that may affect your mood and promote irritability and other sleep deprivation problems. But there is insufficient evidence to support that there is a cognitive risk or benefit of hormonal therapy to aid sleep. Weight gain. You hear it all the time. There is a great potential to have increased weight gain during the perimenopausal period. The body mass index, the ratio of your weight to height, peaks between ages 50 and 59. The average age of the average weight gain during the menopausal transition is 5 pounds, and this is likely more related to aging and lifestyle changes rather than a change in your hormones. The weight does rearrange itself. Anybody can agree that during menopause. So we get this, what we call truncal adiposity, which is just a fancy way of saying you get more fat in your midriff or the muffin top area. This weight increase tends to be a result of, it's like a unequal equation, because you have a decrease in your energy expenditure and an increase in your energy intake. You know what that is, right? You are moving less than you are eating. You're eating more than you are moving. As well, with aging, your muscle mass decreases. Muscle will burn more calories, and so when you're not doing as much, you're not building as much muscle, you're going to retain more fat. Obesity is associated with a variety of adverse health conditions, and obesity is associated with more intense vasomotor symptoms. Things like decreasing your calorie count, even 400 to 500 calories, engaging in more regular physical activity, increasing the consumption of fruits and vegetables, lowering your fat intake, have all been shown to help sustain weight loss during this time period. Increasing your exercise will build up your muscle, and I just said, so the more muscle you have, the more calories you will be able to burn. So I can't stress that enough, like engaging in a good exercise program. It's also very good for strengthening your bones. If you're struggling with your weight, this is where you should come in and have a talk with your doctor again to see if there are things that we can do to better support you in your efforts. Again, you don't have to suffer in silence. And I like to think, again, you can't blame everything on menopause. I like this one. This reminds me of my grandmother who used to feed a lot. I remember when I was little, she got pulled over, and it's like, then she started blaming on me because I needed to go to the bathroom. So this would be her in court using menopause as her defense. I'd like to think of menopause as this time to increase your power, to start opening up discussions about how you really want to live. You know, it's inevitable. We're all, if we live long enough, we're all going to go through menopause. The question is, how are you going to live? Is that going to be a healthy life, or are you going to be like a dwarf? This is the time where you want to engage in a better, healthy lifestyle, discontinue any unhealthy habits you might have, ingest more healthy food, exercise, and I just listed a couple of other things you can do to begin to live your healthiest, best life. So we're going to take a little bit of time for questions this time from our live audience as well as our web audience.
Question just so
Absolutely.
So I just was thinking to myself that your description of hot flashes makes me sound like they should be burning a lot of calories. I also thought that at one time I was put on niacin. And taking niacin also, I don't think I'm having hot flashes yet, but I think taking niacin felt like what you described.
Yeah. And for those of you who may not know, niacin is a drug that we've used for cardiovascular reasons for a long time. And one of the things that you learn about niacin, it does cause a lot of flushing. So, yes, you are correct.
So if any guys want to see what that feels like,
Go take some niacin.
over the counter.
Yes.
My cousin, her gynecologist told her about the vaginal dryness. Use the vitamin D pill, prick it a few times, dig in your vagina when you go to bed, and it will moisturize you. Heard of that?
So the question is whether or not we should or could use a vitamin E tablet in the vagina. I have not heard that one. I do hear a lot, you know, because I am a surgeon, and so over the years, people often will come in having applied vitamin E to their cervical wounds, and that's not necessarily recommended, and I don't think that there is good evidence to suggest that that really, really works.
You talked about hormone therapy being a good option for some women. How do they determine if you're a good candidate for hormone therapy?
That's a really good question. How do we determine if a woman is a good candidate for hormone therapy? So first of all, what should be happening is you come in for a health assessment and you have a conversation with your doctor. So one of the things we need to discern is how severe your symptoms are. I have many patients who will come to me and they will leave not necessarily with a hormone therapy prescription because it's not right for them. I do go through the steps of evaluating what are your cardiovascular risks. So we like to get a baseline assessment of your cholesterol and your lipid levels. I want to see that you've had a mammogram in the last 12 months to make sure that there are no, that you don't have an increased risk for breast cancer. And we try to individualize and tailor that down to see what is your biggest complaint, what are your health risks, and if treatment is appropriate for you, we can prescribe it. Now, we do have a variety of different ways in which we can give hormone therapy, and that also depends on your health risk. We can give it through the skin, so it doesn't have to pass through the liver, and if that works, that's great and awesome. But that may not work for the next person, and she might have to take it orally. So it has to be individualized based upon your health history and the level of symptoms. If you're only having a hot flash every now and then, we have to decide, are the risks associated with this drug really going to be worth the benefit?
I wonder what you thought about vitamins, because I was taking Black Cross for a long time and then found out that it could cause acute liver problems. And so I stopped that and started vitamin therapy with the B and not completely, getting rid of the hot flashes, but it's minimized them. But I don't know if it's because I'm getting older too. So what are your thoughts about those versus any?
So the question is, what do I think about vitamins? So we have all sorts of herbal medications, black cohosh, kava kava, and many of the just standard vitamins are touted as good treatments for menopause. But the data doesn't really back that up, that those things are effective. So again, estrogen would be the most effective treatment for those hot flashes and night sweats. There are many women who, for whom estrogen will not be indicated. There are women who are at increased risk for breast cancer, who have other cardiovascular risks, and so estrogen should not be used. In that case, we do have some of our antidepressants can be used. Again, that's where you need to come in, have that conversation with your doctor to figure out what would work best for you. Yes?
I had an emergency hysterectomy that put me into surgical menopause, and I was young, and it's only been 4 years now. But how do I know? And I'm taking hormone replacement therapy. The patch didn't work, so we played around with it. Because I did have like the depression, and it just all hit me like a brick wall. How do I know when I can stop taking? I mean, like, if I'm already in menopause, how long can I expect to be on this hormone replacement? Like a normal woman who naturally goes into menopause.
Really good question. So essentially the question is, or if I may restate, when you go through surgical menopause and you're put on hormone therapy at an earlier age than what you would be prescribed perhaps if you went through natural menopause, how do you know when to stop? Anytime, whether it's because of if it's for surgical menopause, it depends on at what age we started or at what age the surgery was performed. For most of those patients, I will take them to age 51 at least, the average age of menopause. I would want them to be replaced with estrogen because estrogen is vital for your bones and it has some other health benefits. For patients who've been on hormone therapy and they're trying to decide when is an appropriate time to stop, I will advocate doing what I call a drug or estrogen holiday. And that is you stop the hormone therapy for a short period of time and we assess your symptoms at that time. I never advocate that we do that in the summertime because then it becomes hard to discern if you're having hot flashes or it's just hot.
We have some related questions to surgical menopause. One is I was taking hormone replacement therapy. This is a woman who had surgical menopause at the age of 28, but now it's not working. What can I do now to control my symptoms? And then another gal is asking, she used to take hormone replacement therapy. Is there a risk of going back to it once you stop?
Good question. A woman's health risk and benefits are going to change over time as she ages. And what might have worked for her in this case, we don't have the age of this woman currently, but she's likely been on hormone therapy for a long time. It may be that we need to just change the formulation. It's hard to know for this particular patient, but we have many different ways of giving the hormone therapy, so we might be able to tweak it by giving it in a different route. And the second part of the question?
So if I've been on hormone replacement therapy, stop, can I go back, or is that risky?
What we know is for women after 3 to 5 years of therapy with estrogen, the breast cancer risk does increase. So we like to keep that in mind. But this is where individuality comes in, and you have to have a conversation with your doctor. And I know I keep saying that over and over, but women are different. And so if I do have some patients who have been on hormone therapy for years, much longer than 3 to 5 years, there are many patients who are going to have severe hot flashes. 9% of women beyond 70 will still have severe hot flashes. Are those women not to be treated? If it's really impacting their quality of life. So that's where you have this conversation about, does it make sense? And if you are accepting of the risk and your doctor feels comfortable for you, it may be appropriate to continue therapy. Other questions?
Another question. I know you had earlier in the presentation said 5 pounds for weight gain. Then how come after I had my surgery, it was a matter of 3 to 6 months, I packed on 30 pounds, and my lifestyle didn't change. It actually got better because I was so depressed, as you know, that I tried to get back to exercise, change my diet. I've never been a smoker, not a big drinker. So my lifestyle was very healthy, and it still is, and yet I still cannot lose that weight no matter what I do.
It could be that there are other, I hear this so much, and there are other health issues that could be going on that impact our the way in which we hold on to weight, that impact our metabolism as well.
I have an IUD. I've had one for decades. I'm child-free. When do I stop? So one of the hard things about, I'm pretty sure I'm scared that I was in a 48, so but I have very few. I'm here because of her. Yeah. Because I have all of them. I'm trying to get all of them, and I'm thinking, God, I got to keep the coil in there forever.
So everybody's going to be calling me tomorrow to get the coil.
So what, do you have any, and I have a doctor, a PA that I work with that I adore, but I just haven't answered this question of how long does it take for me to have, just using it. I would like to be on the safe side, the other side of it before I don't use it, because it works really well and I'm happy with it. And are you talking about using it for birth control or for
both? Either. And that was a good follow-up question, because there are many women who take for granted you can get pregnant during this whole perimenopausal phase or perimenopausal phase. The ovary is declining in function, but it only takes one egg to be released. So one ovulation, and then I'll see you in my office, and I'll happily take care of you for 40 weeks in a pregnancy, right? So if you're, for contraceptive purposes, and we get this a lot because we are using a lot of long-acting reversible contraception, like the Mirena IUD or the, which lasts for 5 years, and for the Mirena, many women will not have menstrual bleeding. So it's like, how do you determine if you are indeed menopausal? Right. We would encourage you to at least keep it in place if it is still good and hasn't expired until the average age of menopause. And while most times we don't recommend checking hormone levels to determine whether or not if you're in menopause, that might be an appropriate thing that your doctor or your PA would do at that time. The Mirena is providing progesterone local to your endometrium and your uterus, so it does protect you from the effects of estrogen. But you don't get a lot of systemic effects, so it probably isn't staving off hot flashes or night sweats for you.
Okay.
You're just fortunate.
Yeah, my mom had horrible hot flashes when I got there. Yeah.
And everyone is different. Everyone is different. You may go into menopause about the same age as your mother or your sister, but your symptoms could be different.
Yeah. Thank you.
I, first of all, preface this by saying I'm a doctor, so I have no medical history to base any of this on. I have had issues menstrually since it started.
Mm-hmm.
I ended up having an ablation about 3 years ago, and now I believe I'm in perimenopause, only because I went in and had to have a biopsy done on my breast, and it came back fibrocystic changes. And I looked it up. Not supposed to do that, but I did anyway. And it says it's the beginning of menopause or whatever like that. So when would I know? Because I don't have bleeding from the ablation, and I go in every year because I don't have a history. So I don't have, like my mom started at whatever age or whatever.
And you're not having irregular bleeding.
Nope. And I don't have a partner, so I'm not using anything for birth control. So I wouldn't know when menopause. I'm just guessing that it's going to be within the next 2 years or so, because I'm 49 now. But would that be where I would have my doctor do hormones for me?
You don't necessarily need your hormones tested or to see if you're going through menopause. We don't necessarily need to do that. You know, if you're not having symptoms, you might sail right through menopause. But not everyone needs treatment.
Right.
You know, menopause isn't pathologic. You know, it isn't a disease.
Oh, I can have a hot flash, let me guarantee you.
It's just, you know, it's normal. So we don't necessarily need to know for sure that you are in menopause.
I sleep with 2 fans on every single night.
Then-
It doesn't matter what time of year, it's every single
So
night.
then you may be in menopause. But there's nothing to be gained by knowing definitively your hormone level.
Right, I also had polycystic ovary syndrome, so they think I probably started at least 5 years ago.
Good question.
The last couple of years have been on and off like mountain highs and have extreme itching in my hands, my feet, my skin crawls. I've been to doctors, and they just put me in Zyrtec, which works, but I'm wondering if it's part of perimenopause. Are there unexplained things that happen to your body?
The question is, this person is experiencing itching, hives, things that sounds like more of an allergic reaction.
Right.
So your question, is this attributable to menopause? We don't have any good data to suggest that, and actually I had a patient very similar, with a similar story just about a month ago, and I couldn't tell her this was because of menopause. With aging, things change, your body changes, and many of those changes might occur about the time you experience menopause, but I can't say it's due to your declining estrogen level. I wish I could. I want to be able, like, one of the reasons I am a doctor is I want to help people, I want to fix things, but sometimes I don't have the answer. Yeah.
My question to you is, do you find it frustrating as a physician to work with insurance with prescribing hormone replacement therapy to women? Because the lowest price I got, and I will not be given the patch, I would have to pay out of pocket for that. The lowest price I get on Lopreza is $42 a month. Now, I don't know how much the prescriptions are for erectile dysfunction, but are they $42 a month? And maybe $42 a month isn't much. I don't know. I mean, we pay more for our phones, and I have to take that into consideration. But I think there's some discrimination going on.
I'm trying to bite my tongue, right? It is varied. I have experienced a fair amount of frustration over the years in trying to take care of women. And I think in many cases there is a lot of inequity in how much we have to pay for things or even what things are available to us. Just my nurse Julie is here. So I think just in the last 24 hours, we got a phone call from a patient who I thought this would be a really, really great treatment for this patient. And she wrote back and told me it was going to be $200 out of pocket. Right? A month? That would be every 3 months. Every 3 months. And it's, yeah. So
That's the lowest.
And it can get really expensive. I have, practiced in different states, and so different insurances cover things to different levels. So it is frustrating. Because it's often frustrating for me because I can't tell you how expensive this therapy might be. Do I end up sending all of these, different prescriptions to the pharmacy so that you're not, I try to make it convenient for you so you're not having to call back and we're not going back and forth with this like phone game with the pharmacy. So to answer your question, is it frustrating? Yes.
Is it fair? No.
I try to be vocal about these inequities. Part of our advocacy with our, like our National Menopause Society, we do those sorts of advocacy work because we do recognize there is, we don't have a Bob Dole for women's sex dysfunction, and so we're a little bit behind the times. So.
Well, if they don't get partners that cooperate because they have all these issues going on, then how can you medicate it? Then they're just going to, I don't know.
Yeah.
It doesn't make any sense.
We have a great segue question from our webinar attendees, and it relates to partners. So she would like to know, you had suggested that talking to our partners if we have issues with sex, after explaining what's going on with me physically, what really can we do, or what can he do, what can I do? Sort of related to that, we had a question about whether there is statistics for sympathy menopause in men.
I will answer the second question. I don't know of statistics for sympathy menopause. So what can you do, or what can your partner do? So when I tried to survey my own family about this whole menopause topic, which is really interesting. Again, I grew up in Alabama. And we don't talk about, like if y'all don't talk about it in Madison, we really don't talk about it there. So I said to my mom, like, so what did your mom say about menopause? And she was like, well, we just didn't talk about it, like we don't talk about it. And I called one of my older cousins and I said, like, what would you say to women about menopause? Or what did, like, grandma say to you or your mother say to you? And she said, like I was really suffering and my sex life was suffering. And so she said, I had to sit down and I talked to my partner. And he was, frustrated too because he was afraid he was hurting her. And then they're both pulling away. And so she said, you tell those women they've got to talk to your partner. And then you may have to mix it up. You might have to spice it up. You may have to do something differently. So he may need to apply the lubricant. So, maybe that helps. Or, like, you just have to start thinking about things in a different way. It may not be business as usual, and you have to think outside the box. So to speak.
They don't do that. I lost mine because
You lost your.
because he wasn't open to talk about it. He didn't understand it. He thought it was more like in my head.
Mm-hmm.
And I mean, it was not only was I dealing with the depression and the waking and feeling like I was 75 years old overnight, and all the other stuff, but he couldn't handle it.
And that
was hard. It was very hard because then that puts you into another state of mind, you know.
you get into this endless loop.
I do, and then I'm thinking, I am 43 years old and I'm dealing with this, you know. And it was something we had openly talked about with my doctor. Is what we weren't sure it was going to be a hysterectomy when I went in there. It was after I woke up and found out about it. And so, you know, right away my thought was like, oh. And we talked about it together as a couple.
So, you know, I am the kind of doctor that I'm very open to having partners come into the office and we have conversation about this. And I have a conversation with your partner as well. You know, if you want to bring your partner in, we come in, we talk about how we can get through this together. And thankfully, we have other resources and sex therapists, and we can point you to people who can help with the counseling and try to anticipate when some of these problems might arise.
Do any women in this audience have any experience with a woman's touch? Isn't that a place that could be helpful to, you know, the woman who asked the question, and for couples to go to a place like that together? I mean, if it's important enough to split up over, you think it might be important enough to take one big leap to, you know, this is a hard thing, and guys do, women have been dealing with this and talking about this their whole lives, and men might need some help. I'm a nurse. I meet guys who've never been to the doctor until age 50-something. They just don't know how to talk about this. They just don't get it.
So the conversation has to be open, and I frequently rely on other resources in our community to help patients with sexual dysfunction. It's a multifactorial problem. It's not just all related to menopause or a dry vagina. There are many things that go into having a healthy sexual relationship and impact your self-image, the way your partner sees you. So it is very complex.
Well, I like the thing you said, use it or lose it. Well, I haven't had a partner in about 15 years, so I lost it a long time ago, apparently.
You can bring it back. You can bring it back. But the thing is, and so here's what I do ask people. I never assume that you necessarily want to bring it back. Not everybody wants to have sex. And so that, you know, let me just free people up from thinking that everybody is having sex. You know, like what you see in Cosmo and Glamour is not true. You know, like, and it's not necessarily a problem if you don't want to have sex. You should have the kind of life that you want to have, you know, so sex or no sex. Use it if you want to use it and you don't want to lose it, but if you don't care, I don't care if your vagina is like dry and pale. If it's not causing you any problems, it ain't a problem for me. Once it's dry, it's always dry. Is there like cycles to that, or so the symptoms won't get better. So this is a normal phenomenon of aging. If we treat you, it can get better. We can bring back some of the moisture, the elasticity. But if you stop using the treatment, then it's going to return. So oftentimes when we're giving hormone therapy for vaginal symptoms, we'll do it daily for a couple of weeks, and then your maintenance might be once or twice a week.
I have a question too. My situation was before I went back to work, my surgeon had left. I got the letter from Unity saying no longer can see this person. So when you're having some problems, do you think that a primary care can manage these, or do you think somebody should establish new care with another OBGYN person, since they never really got a follow-up with their surgeon because their surgeon had left before they even went back to work?
Surgical care and surgical follow-up often should be initially followed by a surgeon, someone of the same specialty. And it depends on what the degree, you know, what your surgery was. And then we often partner with primary care physicians, internists, and family practitioners to help us with ongoing management.
I just had one thing that I would like to say is that I love menopause. I thought it was great. And I just feel like there's this whole piece of it, like you lose all of that up and down emotional stuff that happens. Maybe because I didn't have a huge amount of hot flashes, even though I still get them. But I think you started talking out in the beginning, like this is also like a great thing in so many ways. You don't bleed every month, and the emotional part is gone, and you don't have to do pregnancy. So I feel like we need to think about that too. You know, we did talk about that.
Absolutely. I had a patient tell me last week, I like it. She says, I'm just trying to keep everything up, like I feel more, well adjusted. There are things that I don't have to stress out about anymore. Another patient said to me, you know what, I don't have to worry about being in a meeting anymore and having blood run down my leg. Or I don't have to worry about, like, when that time of the month comes, am I going to flood my sheets? That is very, like, liberating in many ways, if you've been having periods for a long time. So there are many wonderful and positive things. It's not just about the bleeding, but, we're at a time where we tend to be a bit more in control, and you can just, have more freedom. So it's a matter of perspective. And I would encourage you all to think that, you have a hot flash, and maybe this is just my personality. Things happen, you deal with them, and you keep moving. Get a period, you deal with it, you keep moving. Menopause is going to happen. We deal with it, we treat it, and we keep moving. I can't stress enough. You've got a lot of life to live, and only you can decide how you want to live that life. Don't let these symptoms control you. Let's find a way to manage it. And not, like many of you are saying, well, you probably haven't ever had a hot flash, and like, whatever. But, I get them. Every now and then. I got quite a few today in preparation for this talk. But you deal with it, and you have to move on. The more you think negatively about it, the worse your symptoms are going to be. And we have data to show that.
I'm with her in one aspect. I have been praying for menopause for years because I have had migraines where I was sick 5 to 6 days a week. I can tell you, as I've gotten closer to that magic
menopause, you can call it.
My migraines have gotten less frequent, less severity, and I'm hoping, because I do know that they were hormone related, that they finally go away permanently.
We are in mid-year.
I just wondered, other than the estrogen vaginal way treatment for vaginal dryness, I know you showed some vaginal and other things. What is another natural product? I've heard coconut oil, things like that. Is there something that you would recommend that could be more natural, that would be temporary but would help with that?
We get that question a lot. Questions about the coconut oil, because I think there are a lot of good benefits to coconut oil. You just have to be careful, because here's the thing, even in my non-menopausal women, people use all sorts of things in the vagina, usually around the Christmas holidays, when people are exchanging a lot of gifts. And I've seen this over the years. People exchange the lotions and the body washes, and then I get a whole rash come around January of people coming in with vaginitis and vaginal symptoms.
Oh, I had a rash too.
Yeah, right. Because people have sensitive skin, and so when you get to menopause and that skin is already dry and frail, those chemicals or products can cause even more irritation. So you have to be very, very careful, especially of those oil-based products. You can try it, and hopefully you won't have to come see us.
Yes. My question is, I had hysterectomy when I was 40, but they left my ovaries in. So I'm curious if, without the uterus in there, hanging out with the ovaries, would that have caused me to go into menopause earlier? With, does the uterus, and the ovaries hormonally, do they interact in terms of what your level is in your body?
So the uterus is not a producer of any of the hormones. It is a recipient of the ovary, the estrogen and the progesterone produced by the ovary. What we do know is women who undergo surgical hysterectomy may go into menopause 1 or 2 years sooner than natural.
You haven't touched base on chemotherapy or radiation. I got diagnosed with lymphoma, and I was having hot flashes, night sweats, attributed to menopause, and it wasn't. It could have been some of it, but when I was allergic to the chemo, which kind of whacked my whole system out, so they stopped that. But my question is in that they figured it pushed me into menopause, so they tested me because they wanted to know, okay, what's going on here. To come to find out I was postmenopausal. Now whether that pushed it through, touch base on that. Will that push you through menopause? And if so, with that chemotherapy that I had that I was so allergic to, is some of the effects going to linger on, make my menopause worse? It's awful for me. I mean, I'm up all night. Of course, I can't do any hormonal therapy because of it. I guess just somebody with cancer.
That's a really good question. I appreciate you asking it. So the question is, how does chemotherapy, or what sometimes we call an induced menopause, affect your symptoms? So patients who will be treated with chemotherapy or radiation in their younger reproductive years may experience some temporary dysfunction of their ovaries and have menopausal-like symptoms. They may recover. The closer you are to menopause and you're undergoing chemotherapy that could affect your ovaries, it will likely go ahead and induce menopause sooner. Anytime menopause is induced and not natural, those symptoms may be more severe and intense. Now, the duration may not necessarily be longer, but the initial intensity could be greater.
Yes, I think we're going to have to wrap up after one more question.
You touched a little bit on metabolism and maybe but can you speak more about the changes to your metabolism? Is it estrogen-based, or is it just aging, or and the effects? Because I think that's also contributing to weight gain.
So the question is, does estrogen affect your metabolism, or is it aging? So it's more the aging. As we get older, we're just not as metabolically active. As we get older, we're going to have less muscle to help us be metabolically active. And then, if you're aging and not as physically active, you can see more retention of weight. Well, I want to thank you guys for this fantastic discussion. So it's safe to say that women going through the change, you guys have let me know, I think I got this right, you probably don't want to be one of the 7 dwarfs. And, perhaps you really don't want to be like Elsa, the menopause queen. I mean, like, who really wants, you guys are older than the Disney phase. But, perhaps you want to rock menopause like Samantha from Sex and the City rocks menopause. But when I think about a menopause rock star and who I want to be like in menopause, it's going to be like Tina Turner. This is Tina Turner at age 50, and she's in this campaign called "What You See Is What You Get." So this is Tina at menopause. And prior to me moving to Madison, I lived in Kansas City, and in 2008, Tina launched a new world tour. She's at 68, launching a new tour. And wow, she was amazing, because before I knew it, I was like standing in my chair, and I'm like rolling on the river, and the security guard's like, you need to get down off the chair. And I'm like, I'm all into it. So this is how I want to rock menopause. And this quote just really stood out for me, because the paper asked Tina, like, so what do you think about aging? And she said, my senior life is so much better than when I was young. The wisdom, the way I think, my attitude towards things. There is a change when you are still healthy and you still look good. You don't mind being 68. You look forward to going forward with that same attitude and that same look. That number doesn't mean a thing. So I just want you guys all to go out there and live your best life, whether you are perimenopausal, menopausal, postmenopausal. Step away from the cliff. Men, pull somebody back off the cliff. And remember, the biggest change that you can make when you're undergoing all of these changes is the change in your attitude. So with some lifestyle modifications, some good power tools, I think that you can sail through the change. So thank you guys so much for coming.
Don't leave. I have three quick announcements before you go. I know it's late, but I thought it was great to listen to the talk and to listen to all the great questions and answers. First, I just want to let you know about our next, maybe not our next, but another educational talk coming up September 21st. And this one will be on bladder health, and it features Dr. Christine Heisler. So mark your calendars for September 21st. A sign-up page will be posted on the UW Health website later this year. Second, I'd like to remind everyone that this webinar has been recorded. So if you'd like to check it out later or share it with friends or family, go to uwhealth.org/menopause, and you can look at the webinar online. And then last, you have a lavender paper and evaluation form. So if you could, it was either probably maybe on your chair.
Yep.
Yep. So if you could fill them out before you go, either leave them on your chairs or just give them to one of us at the door. Thank you so much for coming today.
Thank you. Oh, and if anybody leaves out the doors, because I work here, you can't get back in, so don't forget anything inside the building.
Right.